Welcome everyone to the Student Research Spotlight session. My name is Elena and I used to be the president of the ISPOR Sydney Student and ECR chapter up until this month. And I will be chairing this session together with Dr. Ingrid Cox, who is the president of the ISPOR Victoria and Tasmania student chapter. In this session, we will have presentations from 5 students and early career researchers who we selected based on the abstract submissions that we received. And before I begin introducing our first speaker, I would kindly ask you again to please save your questions up until after the presentation, or feel free to post any questions that you might have also during the presentation using the chat function. Now, our first speaker for this session is Dr. Cate Bailey. Cate has recently submitted her PhD thesis in health economics at Monash University on improving intergenerational health and has now taken up a position in the health economics unit at the University of Melbourne. She is an early career expert in statistics with a master's in applied statistics from Swinburne University, and she has a PhD in forensic psychology from Deakin University. She specializes in the analysis of large longitudinal data sets, and the current focus of her research is economic evaluation in the social care sector and measuring quality of life in children. Some of her previous projects include cost effectiveness of lifestyle interventions in women's health across the reproductive cycle and the use of health economic methods in evaluating interventions for socially disadvantaged children. Today, she will be presenting her research on economic evaluation methods to prepare health and social care systems for future demands. So I'll hand over to you, Cate.
Thank you, Elena. I'm just checking that I've got the right screen shared.
Yes, I can see the presentation mode.
Fantastic, thank you. Hi everyone, I'm Dr. Cate Bailey, and as mentioned, I'm just finishing up a second PhD at Monash University's School of Population Health and Preventative Medicine, and I've recently joined the Health Economics Unit at the University of Melbourne. And I'm going to present today work from both institutions with a focus on health economic methods in the social care sector and how this will help prepare health and social care systems for future demands. I'll start by presenting some of the issues associated with doing economic evaluation in the social care sector, and then present 2 completed studies from my Monash work, followed by 2 proposed studies from Melbourne to investigate which questions we should be asking about economic evaluation in the social care sector to improve health and social care systems for the future. Effective health systems are intertwined with patients' social care needs, particularly for vulnerable populations such as children in out-of-home care, the elderly, and those experiencing adversity. Despite this, cost-effectiveness studies in the social care sector are rare, and appropriate economic evaluation methods are required to meet the future demands of the health and social care sectors. Interventions in the social care sector may affect health and well-being, involving measurement of intervention effects, intervention costs, and downstream costs so that we can make effective policy decisions. As it says in the comic, we need to understand efficacy and effectiveness and then take that next step to whether the intervention is cost-effective rather than stopping at that first rung. So here I'm defining social care as the sector providing physical, emotional, and social support to help people in their lives. Housing, legal issues, social concerns are included here. Calculating the cost of care is challenging, and a report from 2010 estimated that the cost of paid care in Australia was $111 billion, representing almost 9% of GDP, whilst the cost of unpaid care was staggering at over 50% of GDP. Methods used for economic evaluation in social care tends to be borrowed from the healthcare field and may not be fit for purpose. Some of the reasons that methods may need to be adapted, including that it may not be possible to conduct randomized controlled trials in many social care areas. And we find we're less likely to have robust effectiveness data, so it can be difficult to interpret study findings. And it may be challenging to compare across interventions in terms of value for money. In healthcare, we often use quality adjusted life years to do this, otherwise known as QALYs, but is this appropriate in this sector? There are two broad reasons why individual randomisation may be more difficult in the social care sector. Many populations in the social care sector are experiencing adversity, and it can be challenging or not even possible to define a control group. If a control group is included, there is a risk that it may have atypical participants. Frequently, the intervention has already been implemented, but we still want to know if it's cost effective. Ethical reasons may include withholding an intervention to obtain a control group, the ability to obtain informed consent, and protection of the participants' privacy and confidentiality. Thus, there may be multiple barriers to randomisation, and this requires methodological solutions. To start answering these questions, we conducted a systematic review of economic evaluation methods used in home visiting interventions, which we hoped would guide us for upcoming cost effectiveness analyses. Of the 21 included studies, many use techniques that would be seen in healthcare, such as cost effectiveness, cost benefit, cost consequence analysis, and there was one cost utility analysis. Where randomisation was not feasible, research designs included parallel cluster randomised trials, pre-post intervention effects, and a cost study across agencies. Threshold analysis was an economic evaluation technique used to estimate the effects where a control group was not available. For our cost effectiveness study of a family preservation program aiming to keep children at home when the family was in crisis rather than going into care, we used a simple decision tree model. This program was a timely, short and intense intervention, and we had a naturally occurring control group that was formed by families for whom there was no availability in the program at the time. However, the control group was small and the demographics didn't fully match with the intervention group, suggesting that there may be issues with comparability. Because of this, we conducted threshold analysis, the technique that we found through the analysis and the systematic review, to demonstrate what percentage of children remaining at home in the control group would be required for the program to be cost-saving or cost-effective. And we hope that this would be useful for policymakers in the future. I'm now working on a range of economic analyses in the social care sector where we can see these issues arising. And one of these programs is a collaboration with the CRE in childhood adversity. This project aims to increase referrals and use of services in disadvantaged areas. An RCT had originally been planned, but there were a range of issues with individual randomisation which prompted a rethink. These included withholding services to obtain a control group and targeting the intervention to the group of interest to see what works for whom and when, rather than measuring outcomes for participants that may not be relevant in the analysis. On this basis, the team decided to change the research design to a pre-post realist evaluation, and thus we won't have a direct comparison group. So what are the implications for the economic analysis? How do we measure the effect and compare this to the costs of the intervention and downstream costs? Further, if we increase referrals, health service costs will also increase. Theoretically, we hope that increased use of health services now would have a downstream positive effect on reducing costs longer term, but costs would increase in the short term. And to answer this question, we also have a series of studies investigating how we can measure the value of unmet need. In a second example, we've applied for funding to deliver a parenting program to kinship and foster carers to enhance outcomes and reduce placement breakdowns for children. So for outcomes, we need to investigate placement length movement between types of placement and the pathway to permanent placement without the intervention. For instance, what is the usual care is what we're really trying to find out here. This data is not currently available, and we're planning to obtain this through data linkage. We will then try to estimate the cost of change of placement due to placement breakdown by interviewing service providers, determining the cost of practitioners, and through a caregiver survey on health service utilisation. We then hope to conduct a cost effectiveness analysis comparing the intervention group to a matched sample from the data linkage, and a cost benefit analysis to investigate the net cost and cost benefit ratio, combining the information of cost of change in placement with data on the estimated cost of standard care. But we also need to consider how we can collect good quality of life data to calculate quality adjusted life years in the social care sector for situations where RCTs actually can be conducted. We don't know much about health-related quality of life in children, as most of the measures are for adults that we use, and many are not suitable for children's developmental stages. I'm currently working on a large MRFF project to determine how best to collect quality of life outcomes in children so that we can work out how to make qualities comparable between adults and children. Traditional quality of life measures are also unlikely to detect change over time or within groups for carers. In the childhood adversity CRE previously mentioned, we aim to test a new 9-dimension measure, the Euroqual Health and Wellbeing measure. In grey, we can see the health-specific dimensions that are included in the EQ5D, but we are now measuring 4 new dimensions, including loneliness, control, concentration thinking, and exhaustion. And we'll be testing whether this measure with the added dimensions would be more sensitive in detecting differences between groups and change over time for carers, in this case of children experiencing adversity. Economic evaluations in the social care sector pose new questions for health economists that require creative solutions. This presentation has provided a brief overview of some of these questions with illustrative case studies. What we want to know is that what we know is that there is not much economic analysis in the social care sector, but this sector has a big impact on people's health and well-being and huge associated costs. There's a large scope for research examining these issues from a health economics lens, including the appropriateness of individual randomisation, methods that are fit for purpose, and how to make quality qualities for carers and children. I'd particularly like to acknowledge Sanfina Ademi, Helen Skitaris and Kim Dalziel for their support of this work, and I'd love to hear your questions. Thank you.
Thank you very much, Kay. That was a really interesting presentation. And we already have a question from Marty. He would like to know what data sources will you be using for the data linkage?
Thanks, Marty. Yeah, there's a big data linkage linking data from South Australia and Northern Territory. My current supervisor's got access to that because she's in Darwin for a year. So we're hoping that the South Australian part of that will give us some data about placement movement that would then be sufficiently comparable to the data that we'll be looking at in Queensland. It would be ideal, of course, if we had Queensland data, but at least we feel like that is something that is a really rich data source that we can access.
Thank you. Are there any other questions?
If we've got time, I might ask a quick question of the
sure.
audience. I was wondering if anyone has done any economic evaluation in the social care sector and if they've come across any of these ideas.
Can you just raise your hand or give a thumbs up emoji if you've done it?
I can't see very well.
Sanfina has done some, and I have done some, but I can't see if anyone else raised their hand as well. I don't think so. So that's not a lot of people.
Thanks so much for having me on today.
Thank you for giving the presentation, Kate. Okay, then we will head to our second presenter, who is Tichu Ngan. Ngan is a current PhD candidate at the Menzies Institute for Medical Research at the University of Tasmania, and she focuses on research on endocrine and metabolic disease or disorders. Her PhD project is expected to provide new information regarding the economic burden of diabetes in Tasmania, with the aim of supporting the diabetes healthcare community and inform policymaking. Today, she will be giving a presentation on a systematic review on data linkage for diabetic research in Australia. And now please join me welcoming Ngan for a presentation.
Thank you. Let me share my screen. Can you see it clearly?
Yes, I can. Thank you.
Yeah. So, hi everyone. My name is Ngan and I'm a PhD student at Menzies Institute for Medical Research, the University of Tasmania. And today I'm gonna share with you findings from our systematic reviews regarding the use of data linkage on diabetes, on publication on diabetes in Australia. So this is the outline of my presentation today. First, I want to give you a brief introduction. Next are the methods, results, and finally the conclusion. So let me start by telling you a little bit about diabetes. It is a metabolic disorder characterized by chronic hyperglycemia. So it's a chronic disease, right? And what else? What makes this disease so important that you must have heard about it 100 times over? Well, because diabetes can cause many complications influencing any part of the body. So the chronic nature of diabetes and its devastating complications make it a very costly disease. And moving on to our next important concept here, data linkage. So as you can get from its name, data linkage is a method bringing information from different sources together about the same person to create a new and richer data set. And as you can imagine, data linkage provides researchers with a comprehensive range of information as data are collected from different sources. And recently, the number of data linkage studies has increased significantly, including studies focusing on chronic diseases, especially diabetes. However, data linkage uses as well as quality of data linkage studies on diabetes have not been properly examined. So this review was performed to identify the common themes, knowledge gaps, and to evaluate the quality of data linkage publications on diabetes in Australia. So moving on to the next point of the method, we use search terms to search for literature in 6 different databases. We also search manually on the PHRN website, which is a website listing data linkage studies in Australia. And we also scanned reference lists of included studies and related systematic reviews to obtain relevant studies. Studies were included if they were published in English, use Australian linked data and focused on diabetes. Systematic review, meta-analysis, and conference abstract were not included. Screening, data extraction, and quality assessment were done by 2 independent researchers to reduce bias. And the guidelines for studies involving data linkage were used to evaluate quality of included studies. And the guidelines include 14 reporting items belonging to 4 domains. Domain 1 is about data sources. Domain 2 is about data preparation. Domain 3 is about linkage process, and domain 4 is about ethics. And because each included paper used a different number of databases, so for the first domain, we calculated the average number of points achieved in each item. And the total number of points obtained from all items divided by the number of applicable items was quality scored for each study. And categorizing studies as low, medium, and high quality was based on the lower and upper quartiles of quality scores. And the systematic search identified over 5,000 studies, and after two-stage screening, 118 studies were included in the final analysis. As you can see here, the number of data linkage studies on diabetes has increased over the years, reaching a peak in 2015 and decreasing slightly from 2017. And most of the contribution came from Western Australia and New South Wales, and a small number of applications has been performed in Tasmania, Northern Territory, and Australian Capital Territory. And the quality scores of included studies can be seen in the chart. Studies having scores lower than the lower quartile were categorized as low quality. From the lower quartile to the upper quartile, we have medium quality studies, and over the upper quartile, we have high quality studies. And finally, we identified 31 low quality, 55 medium qualities, and 32 high quality studies. And after extracting data, there were 6 common themes highlighted among included studies. And now with the development of data linkage, it is now available for researchers to explore many aspects related to diabetes, especially aspects requiring data stored in different databases. Data linkage studies confirm negative outcomes in diabetic patients compared to non-diabetic patients. They were more likely to die, experienced much shorter lives, and were at higher risk of hospitalization. And additionally, the inverse association between primary care and hospitalization was observed. And data linkage studies confirm risk factors found from previous studies and suggested conflicting risk factors for diabetes and its complications. And finally, data linkage can be used to validate data sources, diabetic models, and instruments. However, there were few data linkage publications in Tasmania, Northern Territory, and Australian Capital Territory. And there were also limited studies investigating healthcare expenditure and adverse effects of medications, regardless of the advantages of using linked data in these branches of research. In terms of studies investigating healthcare expenditure, they were outdated or focused on specific groups, which couldn't provide a comprehensive picture of the total costs related to diabetes care, and there were no studies reporting costs for acute complications. And in terms of adverse effects of medications, studies focused on anti-diabetic medications used for a long time with known adverse effects. And in the future, it is expected that there will be more research providing more up-to-date information on diabetes costs, especially specific costs of acute complications, and studies assessing adverse drug reactions of recently approved anti-diabetic medications. So in conclusion, our study found that data linkage is a valuable tool in diabetes research, and health outcomes of patients and risk factors for diabetes were frequent areas for research. However, there was a dearth of information regarding adverse effects of medications and cause of diabetes care and its complications, and hopefully future research can solve the problem. So it is the end of my presentations. Thanks for your listening and happy to answer any questions.
Thank you for your presentation, Ngan. Please, if you have a question, type it in the chat function, or you can also unmute yourself or raise your hand if you want to ask Ngan something. Someone raised their hand. Let me just check. Tan, you have a question.
Thanks, Ngan. That's really good to see what's currently out there. I was curious to know, because you mentioned that there was not much work in around acute complications. Is that in regard to any like hospital data in terms of hospital acute admissions, or is that something else that's in terms of data linkage? Because I'd imagine hospital data would be something that could be useful to provide data linkage for.
Yeah, actually, I think there are a lot of resources that can be used to estimate healthcare costs using data linkage, such as you mentioned, hospital data, and in addition, ED presentations can be useful as well, and MBS and PBS data are also useful sources to estimate healthcare costs. Yeah, so in my review, actually, for the studies focusing on healthcare expenditure, most of them focus on hospital data, yeah, and primary data. So primary healthcare costs and hospital. And actually, there were no studies investigating costs for acute complications, even no hospital healthcare costs.
Okay, thank you.
Now we've also got a question from Marty.
Yes, definitely. Hang on, that's a really great presentation. So it seems like health data linkage is really important with health economics and public health research. But we know that there are challenges into enabling researchers for data linkage. I was wondering if you can comment on what are the challenges where that may be health system-based infrastructure or political that is currently faced to enable data linkage specifically for diabetic research.
Can you repeat your question again?
Yeah, definitely.
Get it.
Yeah, so I know that for my particular experience with work, though data linkage is possible, there's time delays and it's a very quite lengthy process, which can often be quite a deterrent for research pursuing understanding what's going on in Australia with all linked data. So I was wondering if you can comment on that a bit further and what you think is the biggest barriers with regards to data linkage.
Yeah, I think the biggest problem with data linkage is that maybe sometimes the linkage process is really time consuming. Yeah, it takes a lot of time. So yeah, I think it's the biggest problem. Yeah.
Okay, great. Thank you, Nan, for your presentation. I think we don't have any more questions. It was really interesting, so thank you very much. Okay, we will now head over to our third presentation, which is from Clara Marquina. Clara graduated in biomedicine and neuroscience in Madrid and later obtained a Master of Science from the University of Barcelona. Before moving to Melbourne in 2018, she worked on chronic inflammatory diseases at Karolinska Institute in Stockholm for 4 years and has experience in clinical research of cardiometabolic diseases. And currently, Clara is a PhD candidate at the Health Economics and Outcomes Research Unit in Monash University. Her research focuses on health economic evaluations of different aspects of cardiovascular care in Australia, and it aims to optimize health policies for cardiovascular diseases. She also works as a teaching associate at Monash University, And besides reading with a good coffee or a good wine, depending on the time, Clara loves scuba diving, discovering new places, and long summer dinners with friends. Today, she will be presenting a cost-effectiveness analysis of population genomic screening of all young adults in Australia to detect familial hypercholesterolemia. I will now hand over to Clara.
Hi, everyone. Thanks, Elena, for that lovely introduction. Yeah, thank you for joining today for this presentation. As Elena said, my name is Clara Marquina, and I am a PhD candidate at Monash University. And today I'm very happy to be presenting one of our projects, which is a cost-effective analysis of a population-wide genomic screening strategy for FH. Okay, so first of all, what is FH, or familial hypercholesterolemia? FH is a dominant monogenic disorder, and it's one of the most common monogenic disorders in humans, and it causes elevated levels of LDL cholesterol from birth. These elevated levels of LDL cholesterol in turn cause elevated risk of coronary heart disease, and hence it causes elevated risk of premature death. A recent meta-analysis that included more than 2 million people reported a prevalence of 1 in 250. And currently in Australia, we are only detecting 4% of all the cases that we have. Now, we do have a treatment for these patients, which are statins, which have been shown to be cost effective and are generally very well tolerated and very safe. So with all of this, what's suggested is that there is an opportunity for early detection, and there is an opportunity for preventive care for these patients. And this is how this project came to be. So our model is based both on a decision tree and a Markov model. This is our decision tree. I know the slide is a little bit busy, but I'm going to try to go through it. So if you go from left to right, first we find the green node, which is the decision node, where you have to decide basically, okay, are we doing population genomic screening for FH, or are we going with the standard of care for FH detection? If you decide to go with population screening or a standard of care, the proportion of people in the population with FH is going to be the same, 1 in 250, as I said before. But now, if we follow up, this is where it becomes interesting, because if you see in the population genomic screening cohort, we have the potential to detect 100% of the people that have FH in the population. Whereas right now, in the standard of care, we are only detecting 4% of those patients, and 96% remain untreated and undetected, or at least undetected. Then if we move forward, we also have the potential in the population genomic screening to treat everyone from the moment that they are diagnosed. Whereas right now, we are only treating 64% of the people that we detect. And from the people that we do not detect, we decided to model an age-specific trend for the utilization of statins, because these people will have high levels of cholesterol, so some of them will have treatment. So we use the general population in Australia to model the treatment of the patients that have FH but are currently not detected. Now, once that we have all these people divided into these different groups, we put them into a Markov model. And this Markov model, we decided to go with this because we wanted to model the risk of fatal and non-fatal coronary heart disease, or CHD. And using a Markov model allows us to follow the full progression of the disease. So everyone started the model in the alive with no CHD health state, and in each cycle they can remain there, or they can have a non-fatal CHD event and then move to the alive with CHD health state, where again they can remain there, or they can have another non-fatal event, which will have consequences for the costs and the quality of life. And of course, in both of the states, they can die due to coronary heart disease or due to any other causes. Now, of course, in this model, one of the most important inputs was the risk of coronary heart disease. And for the primary prevention population, we use the risk of CHD specific for individuals with FH in a primary prevention cohort study. Now, we adjusted this risk for age and sex specific rates using Australian data. So everyone will have a different risk depending on their sex and age. And then the treatment effect, which is mostly statins, is also specific for FH patients without established CHD. And actually, we took it from the same study as the risk of CHD. So we thought that that was pretty consistent. Now, regarding quality of life, all the utility weights in the model are adjusted for a healthy baseline. And we did that using an Australian general population. And the chronic and acute coronary heart disease utilities are from the Valiant study. And they measure quality of life 6 months, I think 12 months, and 24 months after a non-fatal event. Now, regarding the economic inputs, of course, one of the most important inputs was the cost of the genetic screening. We decided to set up to $300 Australian based on threshold analysis that we ran. And then the cost of acute events, the cost of pharmacological treatment, and the cost of chronic care, all of those come from Australian specific sources. Now, regarding population and time horizon, we decided to use a life table population, and the starting age is in between 18 and 40 years old. We are using a lifetime horizon, so we are following up patients until they are 90 years or they die with 1 year cycles, because as I said before, we think that this allows us to model the full progression of the disease. And following Australian guidelines, we are discounting all outcomes by 5% annually. Now, we are making two main assumptions that I think I already introduced a little bit in the decision tree. The first one is that we are modeling 100% uptake. So we are modeling that everyone will have access to the test and everyone will say yes. And then we are also modeling that everyone that is diagnosed with FH will undergo lipid lowering treatment. Now, if we go to the base case results, in the third column, you can see the difference in between the standard of care and the population genomic screening. And you can see that with the population genomic screening, we are preventing more than 2,500 cardiovascular events. The cohort in the population genomic screening is accumulating more years of life lived and more quality adjusted life years. And if we look into the costs, the population genomic screening will have lower costs for the acute event and for the chronic cost, because people are treated and they are treated earlier, so less people get sick. But of course, the cost of treatment is going to be higher because we are treating a higher proportion of the population. And then, of course, the cost of screening is only applicable for the population genomic screening cohort. Now, with these numbers, we obtain an incremental cost effectiveness ratio of just below 28,000 Australian dollars. And we can see this result in the cost effectiveness plane. So in blue, we have the willingness to pay threshold of $50,000, and in red, a willingness to pay threshold of 28,000 Australian dollars, which it has been reported lately as the most commonly used. And our result fall exactly into that line. Now, this represents again that upper right quadrant in the cost effectiveness plane. And these are the results of different scenario analysis. So as you can see, we ran a bunch of different scenarios because we wanted to test the impact that different parameters had in the model. And this one here, the gray one, is our base case. And all those around are very similar or better. For example, the blue square far away is what happens if we do not apply any discounting to any of the outcomes. But I want you to focus on this pink one here, because this is what happens when we model a 75 treatment adherence. So in the base case, we have modeled that everyone that is detected with FH and diagnosed will have lipid lowering treatment. Now, what happens if we reduce that to 75%? Well, as you can see, the costs are similar or even a little bit higher because more people will get sick, so the cost of chronic care will increase. But more importantly, we are missing a lot of the benefits if we are losing only this 25% of treating the population. We were also curious to see what will happen if we will reduce the uptake, but in this case, although the benefits are also smaller, but the impact on the cost is not that much because, of course, we are testing 30% less people than in the base case, and that reduces the costs quite a lot. We then run some probabilistic sensitivity analysis, and in the green dots are the results from 10,000 Monte Carlo simulations for the base case. So that's for a cost per test of $300 Australian. And as you can see, for the willingness to pay threshold of $50,000 is mostly cost effective. If we are using the $28,000, not that much, but still I think it was 30% of the times it was cost effective. But if we are able to reduce the price to $80 or $50, which we think is feasible, then we will achieve mostly cost saving results. Now, I know that I have mentioned this, but I wanted to remark that we have some limitations in this model. We are modeling 100% uptake, and we know how difficult it is to have such a wide uptake in the population for public health measurements or measures. But more importantly, we are modeling 100% adherence and compliance with treatment guidelines, so everyone getting treatment, and this has a high impact on the results, and we know that it's also complicated to achieve. Then I also wanted to say that the treatment in this model is mostly limited to statins. We did include 5% of the population treated with other lipid-lowering therapies, but the reality is that most of these patients will need at some point in their lives some kind of other lipid-lowering therapy besides statins. But in conclusion, the take-home message is that population genomic screening for FH could be cost-effective with a cost per test of $300 Australian, and that it can offer substantial health benefits for the population. So that's it for me. I wanted to say thank you to you all, and also to my main supervisor, Associate Professor Sanfina Ademi. And also I want to say thank you in this case to Dr. Paul Lacasse for including me in this project, and to all of you.
Thank you so much, Clara, for your great presentation.
Thank you.
We've already got a question from Tan. He asks, how are people being diagnosed? I assume symptoms occur before someone is referred for the genetic test.
So currently in Australia, they are doing what is called opportunistic diagnosis for FH. So basically when somebody goes to the clinic and they have high levels of cholesterol, I think there are some thresholds for how high cholesterol has to be in order for them to be referred to a genomic or genetic test that can diagnose FH for sure. And then what they do as well is opportunistic cascade screening. So if somebody has FH, they will test also direct family members to see if they also have the condition.
Thank you. We have a second question from Cate. How can you best estimate the cost of the test per person?
How can you, sorry?
How can you best the cost of the test per person?
So the current cost of the test is 1,200 Australian dollars because it's not widely available and you have to go to very specific labs. But they did some costing for a clinical trial. Dr. Paul Lacasse, which is leading that particular part of the project, and they estimated that they can achieve a $100 cost per test. We decided to set it up in $300 because we wanted to see at what price it will be a cost-effective strategy. So after running threshold analysis, so we built the whole model and we ran we built the whole model and then we did a threshold analysis for this specific input, and then we obtained a $300 as a value for the whole model to be cost-effective. And we think that that is very feasible because in this clinical trial they have already been able to reduce the price to $100.
And as a follow-up question, it probably also is cheaper if you roll out the test population-wide, because then you get the economies of scale.
Yes, but I have to say, I mean, yes, of course, but I have to say that we didn't include, for example, the cost of implementing the genomic screening, you know, to take it to everyone in the population, to rural areas, and the cost of also like making people actually going to take the test. which we know is not necessarily an easy fit.
Yeah. And did you run a scenario for the same treatment rate as the comparator? From memory, 64%?
Yes.
The question from Sopani.
Okay. So to only treat 64% of the population? No, we decided to go with 75 treatment adherence because the guidelines said that everyone that is diagnosed with FH, they are not going to achieve a lower LDL just by lifestyle. So everyone should be treated with lipid lowering therapy. So that's why we decided to go in the base case with 100%. And then we did a model with 75% treatment adherence. We didn't go as low as 64, which is the current situation. But as you can imagine, the results are going to be even worse than for 75%.
Thank you. And now, Tan, you have your hand up.
Yeah, last question. Thanks, Clara. I was just curious because I would imagine, like, although people would be, would be positive for the genetics to have the risk there. I'd imagine that some people may not have symptoms or can be self-managed in a way. So is there any information in terms of that aspect?
Yes, thank you so much for that question, Tan. That is a very important point, and I forgot to mention it in the introduction. So what I forgot to mention is that FH is a highly penetrant condition. So if you have one of the, I think there are 3 main genes that may be affected by specific mutations. If you have those mutations, you are going to have high LDL cholesterol, like 99.99% of the cases.
Yeah, that makes sense. Then that, yeah, it'd be good to see a HTA assessment put through to NBS perhaps.
Yes, and that, to be honest, made the modeling much easier because we didn't have to take into account, okay, what is the percentage of the people that is actually going to have high levels of cholesterol and what's the percentage that is not going to develop the disease. We know that all these patients will have high cholesterol.
Hi, Clara, can I have a question?
Yes, sure, the last question.
Thank you. First of all, thanks a lot for such a lovely presentation. I was just thinking, in the base case, you considered that 100% uptake of the population level screening of this. And then obviously in the sensitivity analysis, you might have tested other thresholds for that. I was thinking, was that informed by the earlier literature with some sort of similar population level screening in some similar disease area? That's one. And the other thing is that because in such a kind of intervention, obviously compliance is going to be one of the very important things when it comes on the real life. So in the real world, when something like this happens, the cost for improving compliance, can that also be accommodated somehow in the model, whereas it gives the it tries to give the actual impact in terms of cost effectiveness? Because that is something which I feel in the real world is going to be one of the important things. Yeah.
So yes, thank you for these questions. They are very relevant points. To answer your first question, the 70%. So in the base case, we decided to go just with the base case scenario. What will happen if we will achieve this? Then in scenario analysis, we decided to go with 70% based on another genomic population-wide screening that were, I think it was in Israel, and it was like for breast cancer, and they achieve a 70%, I think, uptake in the population. So that's based on that, but there is no specific data based on FH. So we don't know exactly how that might roll out. I think it can be better because it is a very easily, like you can treat it easily. You know, you don't have to go through surgery or through chemo. So we think that people, like it can be done. You can reach this 70%. And for your second question,
for the compliance part of it, that okay, we say that okay, it's not going to be have 100% uptake. Then are there studies earlier available that have shown some compliance strategies and reported their cost to improve the compliance for any such similar screening, population level screening? Maybe that cost element can be put in a different sensitivity analysis where you say, okay, even if the uptake is not 100%, when you consider this much of an uptake, then this is the compliance cost which you additionally add, and then make it a higher sort of a uptake, and how the outcome might change in that scenario.
I mean, definitely, that is a very good idea to include in scenario analysis. And actually, I'm going to write it down. The thing is that we don't have that information right now. I have not seen any studies that look specifically into how to improve lipid lowering treatment compliance in a general prevention population, in a primary prevention population. So we don't know, but it's something that we can look into and we can include into the model. So thank you.
Yeah, great. That'll be very informative. Yeah, thank you.
Thank you.
Thank you very much, Clara, for your presentation, and well done answering all the questions.
Thank you.
Okay, I will now hand over to Dr. Ingrid Cox to host the second part of this session.
Thank you, Elena, and thanks to the previous speakers. My name is Ingrid Cox, and I'm the outgoing president for the Victoria and Tasmania Student Chapter and the incoming Global Student Network Chair for ISPOR. I'm currently in my third year of my PhD at the Menzies Institute, University of Tasmania. This afternoon, I have the pleasure of introducing Laura McCosker, and Laura holds an undergraduate degree in social science and nursing. She's currently studying a master's degree in public health and infectious disease at the University of New South Wales, and also doing a PhD at Griffith University. Her research focuses on vaccination programs, including for COVID-19, to inform vaccination guidelines for people who are homeless and at risk and hard to reach populations. So with no further ado, I will hand over to Laura.
Thanks, Ingrid. I appreciate that introduction. Good afternoon, everyone. So as you just heard from Ingrid, my name's Laura McCosker. I'm a second year PhD student at Griffith University in Brisbane, and I'm studying with the Centre for Applied Health Economics and Menzies Health Institute, Queensland. So as Ingrid just introduced, my PhD is looking at the impacts of and responses to COVID-19 in people who are homeless, and I have a particular focus on vaccination. Today I'll be speaking about the results of a systematic review I'm currently in the process of completing as part of my PhD, which is looking at how we can prepare health systems for the delivery of COVID-19 vaccination to people who are homeless. So as I'll explain, in comparison to the general population, people who are homeless have higher rates of vaccine preventable disease, and that includes COVID-19. However, for a number of reasons, delivering vaccination to people who are homeless is really challenging. Prior to our study, there were no existing systematic reviews about effective programs to deliver vaccination to people who are homeless. However, this type of evidence is really essential in informing effective and therefore cost-effective vaccination programs for this population. I'd like to acknowledge my colleagues Asma El Hanadi and my supervisors Martin Downs, Rob Ware and Holly Seal for their assistance with the study. I would like to begin by acknowledging the traditional owners of the lands on which we're all located today, and to acknowledge and pay my respects to their elders past and present. To get us rolling, I'd like to define who I'm talking about when I say people who are homeless. So in Australia, a person is considered homeless if they lack access to adequate shelter. So this includes people who are unsheltered or sleeping rough, and those living in overcrowded, substandard, untenable or unsafe housing or in emergency shelters. The most recent national census, which was conducted in 2016, found that more than 116,000 people in Australia are homeless. And this is equivalent to about 0.48% of the population, or roughly 1 in every 200 people. Rates of homelessness in Australia have increased throughout the past decade, and as the COVID-19 support provided by governments is being progressively withdrawn, rates of homelessness in Australia are anticipated to continue to increase this year, and perhaps quite significantly. So as I mentioned in the beginning, in comparison to the general population, people who are homeless experience far higher rates of vaccine preventable disease, including for COVID-19. Now I'd like to talk to this a little bit more, but I will preface this section by saying that most of the literature about COVID-19 in people who are homeless that's been published to date has come from the US. And obviously the situation in the US, both in terms of COVID and in terms of homelessness, is quite different than the situation in Australia. But I'll talk about that a bit more in just a minute. So what do we know about COVID-19 in people who are homeless? So firstly, we know that people who are homeless have higher rates of COVID-19 infection than people in the general population. So the best population level estimates of COVID-19 infection that I can find are actually from England, where infection rates peaked in January 2021 at around 1.87%. A systematic review, which included 13 prevalence studies, calculated a rate of COVID-19 infection in people who are homeless of 2.14%. We also know that people who are homeless have poorer clinical outcomes in relation to COVID-19. So this is from a study of more than 14 million hospital admissions, including around 29,500 admissions among people who are homeless in Canada. And it found that people who are homeless are more than 20 times more likely to be admitted to hospital, about 10 times more likely to require intensive care, and about 5 times more likely to die with or because of COVID-19 than people in the general population. So far, Australia's been really fortunate to avoid the widespread transmission of COVID-19 in homeless populations and the associated health impacts. And I think there are 2 key reasons for this. So firstly, prior to the pandemic, Australia had in place a range of relatively well-funded services to support people who are homeless. Now, these services are imperfect, and as I said at the beginning, rates of homelessness in Australia are increasing. However, they do mean that people who are homeless are not usually accommodated in large shelters or encampments, which studies from the US have consistently shown to be conducive to the spread of COVID-19. Secondly, Australia also implemented a really rapid response to COVID-19 in people who are homeless. So perhaps most significantly, people with immediate housing needs, so that includes those sleeping rough and those in overcrowded accommodation, were provided with emergency accommodation in 2020. And up to 33,000 people all across Australia may have been accommodated under this program in 2020. And this effectively, although temporarily, reduced rough sleeping in some areas, such as in Adelaide. Now, although Australia has avoided the health impacts of COVID-19 seen internationally, the pandemic and the government responses to it have had really significant impacts on the general population, and this disproportionately affects people who are homeless. So we conducted another study last year, which is currently under review for publication, which found that the pandemic has had significant negative impacts on every aspect of the lives of people who are homeless in Australia. We know that vaccination is the only sustainable option for controlling COVID-19 in homeless and in general populations. So the other main response, which are lockdowns to facilitate social distancing, as we're unfortunately seeing in Melbourne today, obviously have enormous social and economic and psychological impacts. And of course, you can't stay home if you don't have a home. So vaccination in this population is really essential. However, delivering vaccination to people who are homeless is really complex, and there are a number of reasons for this. So people who are homeless and who have had previous negative encounters with health and social care services frequently mistrust and lack confidence in these services, and this may prevent them from actively presenting to vaccination programs. Where people who are homeless have immediate and urgent health and social needs, preventive vaccination may simply be a low priority. Also, people may not know where to go to be vaccinated if they don't receive public health messaging, or they may not have the means to travel to a vaccination program. So as a result, in comparison to the general population, it's generally accepted that people who are homeless have lower rates of vaccination. So we set out to conduct a systematic review to answer the research question, which approaches are effective at delivering vaccination to and at improving vaccination rates in people who are homeless. So we reported our methods in detail in a protocol paper, which has been published, but just in summary, we searched 8 electronic databases using 2 groups of keywords, so those related to homelessness and those related to vaccination. The searchers returned 1,379 articles, and we filtered these to a final total of 21 articles, which reported on 17 separate vaccination programs. The studies were published between 1998 and 2020. Most of the studies, as I said earlier, were undertaken in the US, but there were also studies from Australia, Canada, France, and the Netherlands. And most of the studies actually looked at hepatitis A and or B vaccination, which is actually really useful as this is a multi-dose vaccine similar to most of the COVID-19 vaccines. So we extracted data from the studies about the key features of the programs and also about the outcomes of the programs. So outcomes were often measured quite simply as numbers of people being vaccinated, but a smaller number of the studies also reported on pre-post measures. Because of the heterogeneity of the studies, we weren't able to analyse the data quantitatively, so we did so narratively or thematically. We found that all of the programs were effective to varying degrees at either delivering vaccination to or at improving vaccination rates in people who are homeless. Most of the programs reported on vaccination clinics, either fixed or mobile, and most were delivered at least in part by nurses. However, the programs were really diverse in terms of their other features. We're currently in the process of making broad generalisations about what works according to what most of the programs did. So, for example, most of the programs were delivered at locations which are convenient to people who are homeless. So in the studies, the programs were cited at locations including shelters, crisis centres, community centres, drug and alcohol treatment facilities, meal programs, and other outdoor locations frequented by people who are homeless. A number of the studies use accelerated vaccination schedules where these are available. Most of the studies use some type of active recall or reminder system to encourage people to either present for their first vaccination or return for their second vaccination. So for example, this often involved a combination of reminder cards and reaching out to people either by telephone or even face-to-face. Some of the studies also offered incentives for vaccination, so things like clothing and food vouchers and even small payments, which is actually really interesting considering the current discussions around incentivisation for the COVID vaccination in the general population in Australia. Most of the studies offered training to staff to enable them to work effectively with people who are homeless. Many of the studies also looked at opportunities for co-interventions, so delivering physical and mental health care, so for example, screening and referrals while people were present with healthcare staff. And perhaps unsurprisingly, we also found that collaboration between health and social care providers working with people who are homeless is really vital to ensure that consistent messaging and service delivery. So where to from here? So the next steps for us are to use the findings of a systematic review to inform the design of an evidence-based COVID-19 vaccination program for people who are homeless, which we'll implement and evaluate with the assistance of one of the large homelessness organisations here in Brisbane. And then we'll use the results of this study and the systematic review to inform an evidence-based guideline, which will be used to prepare health systems more broadly for the challenging task of effectively delivering vaccination to people who are homeless. So this will include COVID-19 vaccination, which we expect to continue annually, and also other vaccinations such as for influenza. And ideally, we'd like to see an improvement in vaccination rates and therefore health outcomes in this at-risk but hard to reach group. So thank you very much for listening, and I'm very happy to take questions.
Thank you very much, Laura. Do we have any questions for Laura from the audience? Okay, I see we have a question from Tan. Tan, you can go ahead and unmute yourself.
Hi, Laura. Thanks for
Tan.
the presentation. I was just curious in terms of the literature that you've read through, you know, in terms of the low vaccination rates for this population, is it because there's, you know, hesitancy to get vaccines, or is it more or less like the logistics around it? Because I would assume, yeah, just some understanding of, because I know that many people may want to get vaccines, but the logistics around getting it in a timely manner can be quite difficult.
Absolutely, and it's a really interesting question. I'll be honest and say we actually don't know the answer to it. So interestingly, there's no systematic review looking at vaccination rates in people who are homeless. So there's a lot of smaller studies that say vaccination rates are generally lower than for the general population, but there's actually been no systematic review done. Just in terms of my experience with working with people who are homeless, vaccine hesitancy is very high. So they, as I said in the presentation, many people who are homeless generally mistrust health and social care systems. I think they felt that they've fallen through the cracks, so why should they continue to trust systems that haven't helped them previously? So I think that's one reason. I think the second reason is also something that you raised just then in terms of the logistics. So certainly we've started vaccinating for COVID here in Brisbane, people who are homeless, and the logistics of reaching people, and certainly reaching people with a second vaccine, is just incredibly complex, time consuming and costly. And I think there aren't enough dedicated services to be reaching out to this, like I said in the presentation, what's really an at risk but really hard to reach group. So yeah, I think 2 reasons there.
I hope that answers your question, Tan. I see Elena also has her hand up. Go ahead, Elena.
Thank you. I was just wondering if you would only vaccinate homeless people once, that would already give some protection. And you said especially the logistics of getting people the second time are very difficult. So would it be easier to just target a single dose vaccination rather than trying to really get the higher efficacy of the vaccinations and getting them vaccinated twice?
Absolutely. So it's another really good question. So certainly the COVID vaccination programs that have started in Brisbane here for people who are homeless, we've only ever achieved 1 dose. We can't get people for the second dose. It's better than nothing. Unfortunately, no single dose vaccines have been approved in Australia yet. So at this stage, we're still trying to follow up people, but it is extremely difficult. So in response to your question, I'd say yes, one dose is better than none. But ideally, we'd love to get them for the second dose. And certainly that's something we're going to focus on in this trial that we're planning at the moment, is how to get people back, encourage people to come back. Whether that's going out to people, with a mobile van, that's certainly something we've talked about. Reaching people in the ways that best suit them. Yeah,
thank you.
Just a question, Laura. I was wondering, maybe a comment and less of a question. I was wondering, you mentioned vaccine hesitancy in the target population that you're studying. I'm wondering, is it vaccine hesitancy, or is it that maybe those persons in that population have other bigger priorities, such as mental health issues, chronic diseases that may but require more attention than something that they can't see? So is it more hesitancy or prioritization?
Sure. So I think I mentioned in the presentation that they're often hesitant to present to healthcare services generally. Certainly with this vaccination program that we've started in Brisbane, we started vaccinating with AstraZeneca right around the time that all the data came out about the very low but still present risks associated with the AstraZeneca vaccines in terms of blood clots. So we do think that hesitancy around the AstraZeneca vaccine is one reason that people aren't presenting. I did say in the presentation that they often have so many other competing priorities, particularly people living on the street. Vaccination for something that's preventive, particularly when we don't have huge COVID numbers here in Australia, is often so far down the list. And particularly as rates of homelessness now are increasing and people are finding themselves without a home for the first time, I think I would agree that vaccination itself is quite often very far down the priority list. That said, it's extremely important, and it's something that we as healthcare professionals really need to be speaking with people about when we can get them.
Thanks, Laura. Do we have any other questions? If we don't have any other questions, I just want to thank Laura for this really good presentation. It's quite timely, considering all of the issues around COVID and also that target population that you're researching. So thanks a lot, Laura.
Thank you.
So we will move on to our last presenter, and I have the pleasure of introducing Mr. Martin Vu. Martin is the current secretary of the ISPOR Victoria and Tasmania student chapter, and he's also our incoming president for the next year. Martin is currently in his PhD at the Cancer Health Services Research at the University of Melbourne. His research focuses on the critical clinical implementation of the next generation sequencing technologies for patients affected with blood cancers. Prior to his PhD, Martin has also worked on multiple projects in genomics and also in health economics. So without further ado, I hand over to Marty.
Awesome. No, thank you, Ingrid, for that wonderful introduction. My name is Martin, and I'm from the Cancer Health Services Research Unit at the University of Melbourne. And today I'm also presenting on a systematic review that looks into economic valuations of molecular biomarker tests in blood cancers. So a brief overview of the outline presentation today. I'll provide a brief introduction into molecular biomarker tests and what exactly they are within blood cancers themselves. I also would be talking about the design systematic review before I'll present my major findings and synthesize those findings into a bit of a forward-looking picture about what does this mean for cancer health services. So, by definition, blood cancers refer to when, really refers to when blood cells are not made properly. There are over 100 different types of blood cancers, but broadly, blood cancers can be categorized into either leukemia, lymphoma, or myeloma. In terms of the prevalence of blood cancers, the incidence of blood cancers is the fourth most commonly diagnosed cancer. And in terms of mortality, it's also ranked in same position, the fourth most cause cancer death mortality. So with that in mind, there's a substantial health burden when considering blood cancer for patients, but there's also a huge economic burden as well. And so specific to the Australian context, the total lifetime economic cost of Australian patients diagnosed with blood cancer equates to over $21 billion. Clinically, blood cancers is challenging, particularly with the managing of the long-term and late effect of blood cancer treatment. And so what we mean by molecular biomarkers? So molecular biomarkers refer to changes in the blood cancer biology that can really inform clinical decision-making. And these molecular biomarkers are very well suited to fundamentally transform the landscape of blood cancer management. In particular, the detection of molecular biomarkers will lead to better, more differentiated disease classification based on the molecular profile of the blood cancer, better risk prediction, more targeted treatment decisions, as well as improved disease and treatment monitoring as well. And so the tests for molecular biomarkers are very imperative to personalize cancer management strategies, as well as to improve patient care and survival. And so there have been numerous studies here that looks into the clinical utility of molecular biomarker tests. I have one example here for acute myeloid leukemia and a Kaplan-Meier curve to my right. And there's a lot of information here. I just wanted to really show the red and the blue curves where patients were able to receive targeted treatment based on molecular changes that presented in their malignancy, compared to the yellow curve here where patients receive standard of care. And so patients who receive more targeted therapy have a better, superior overall survival than patients who received just standard of care treatment. And they represent a case study for acute myeloid leukemia. We see this across multiple blood cancers. And so the challenge for the health system that we see is that molecular biomarker tests in blood cancers are not routinely reimbursed, and this is very evident in the case of the Australian healthcare system. And so the question is, why is that? Why aren't these tests made available to patients? Can we answer that question from a health economic point of view, particularly looking into the gap of the health economic evidence? So hence why we embarked on a systematic review that really aims to synthesize the current health economic evidence for molecular biomarker tests for the clinical management of patients with blood cancer. And so I will now start and talk about the design of the systematic review, beginning with the protocol development, which was designed in conjunction, in collaboration with clinical experts here at Peter MacCallum Cancer Centre. The search strategy itself was also designed with an experienced biomedical librarian, and we validated the search strategy with the clinical experts just to make sure that it makes sense. And we registered the protocol in Prospero. The literature search itself comprised of full and partial economic valuations, molecular biomarker tests in a clinical setting. We broadened the scope to include full and partial, just because we didn't really know what the economic evidence is out there. So trying to capture everything. However, we limited the publication date from 2010 onwards, and that's mostly in keeping with the modern era of blood cancer treatment. And we conducted search in 5 electronic databases as outlined here. The screening and the data extraction process itself was conducted with 2 people. So the screening was conducted with 2 independent reviewers. Data extraction was conducted by 1. But we extracted data on these 4 domains of information. So general publication information, what's the clinical application of the test, the economic methods used in the publications, as well as the modeling methods for those that incorporated a decision analytic model in their study. And we assessed the reporting quality using the CHEERS checklist. And finally, in terms of synthesis, we presented the main findings, the results to the clinical experts, and in collaboration with them, we synthesized the conclusions. And so in terms of search results, we were able to identify 1,703 records, but after the process of abstract screening and full text screening, we were left with 14 studies as part of the final synthesis. And so what exactly do we find? Well, we found that there was quite a diverse range of blood cancers that were evaluated. However, the most popular is chronic myeloid leukemia. So out of the 14 publications, 43% of the publications focused on chronic myeloid leukemia. In terms of the test itself, 50% of publications evaluated the test under the first-line treatment setting, and 36% of publications focused on the test to monitor the response of treatment. In terms of the economic and model findings, we see a 50-50 split on publications that were conducted that were considered full economic valuations, so considered both economic and outcome and health outcomes, and the remaining 50% were either cost analysis or a budget impact analysis. Only 9 publications incorporated a decision analytic model in their study, and I just want to highlight here that only 1 of the 9 used a patient individual level state transition model, where the other one is mostly cohort level, either being a decision tree or state transition model, otherwise known cohort, otherwise known as a Markov model, or a combination of both. On the figure to my left is the CHEERS checklist. So each row represents a single item on the CHEERS checklist, and the different colors highlight how well it was reported, whether it was reported, not reported, or not applicable. And so based on the dark blue color that indicates, that represents good reporting, it is quite consistent across all of the different items in the CHEERS checklist. And evidently, when we scored each individual publication on the CHEERS checklist, 64% of publications were deemed high, so scored a score of 81% or higher. But the main question is, what does the actual result say? What does this review say? So based on this particular review, we were able to identify 3 companion diagnostics that were considered cost effective. So a companion diagnostic referred to a test that were able to select the best treatment for patients. And so these companion diagnostics were considered cost effective in the first-line treatment setting for both diffuse large B-cell lymphoma as well as multiple myeloma, as well as in second-line treatment, particularly for patients with chronic myeloid leukemia. But because we also considered partial economic evaluations in our systematic review, we were also able to identify 4 studies that reported a cost saving to the healthcare system. And in each of those 4 studies, they specifically focused on the regular molecular monitoring of this biomarker known as the BCR-ABL transcripts in chronic myeloid leukemia to determine when patients should stop treatment because they no longer have a response to their respective cancer treatment. So bringing this all together, in the past 10 years, there has only been 14 health economic publications on molecular biomarker tests for blood cancers. And so we see this as really quite not a lot of publications within this particular space. And most certainly understanding what is emerging out of the clinical pipeline and what the industry is really focusing on. Not all of the applications of the tests were evaluated. And for those that did, evaluate the tests, they're focused on a very narrow aspect of clinical care, so restricted under certain treatment line, as opposed to adopting a more comprehensive approach to clinical management, so throughout clinical care. And so why is that? And we think that there is a lack of commercial incentive to produce these studies, particularly because we know there are known challenges in economic evaluations within precision medicine. And indeed, though we're talking blood cancers as a collective, individually blood cancers are rare and heterogeneous, which may act as a challenge for other industry or academia to produce that research to show the clinical and economic value of these tests. But also, I think it's also a really relevant point is that the current evaluation framework adopted by health technology assessments may not be specifically fit for purpose in blood cancers. And again, it really comes down to the fact that individual blood cancers are quite rare. So, we know that health economic evidence is a challenge in terms of getting access to these tests for patients, but it's really a question of when and how. So when are we going to get these tests available to patients, and how are we going to do it from a health economic perspective? And we really think that new approaches for the evaluation specific to precision medicine in rare cancers, blood cancers included, is needed, that perhaps focuses more on the operational efficiency of the health system. For example, can we get to a better diagnosis faster at a cheaper cost than the current approach? As well as if a particular intervention is shown to be effective and there's clinical utility evidence, can we just get the test available to patients and consider post-market evaluation? And different innovative solutions to improve availability here. And so we need to adopt that forward-looking approach because as we know, that I presented the current system mostly focused on single molecular biomarking tests, so single molecular biomarkers for clinical indication in the management of blood cancers. And what we know is happening in the clinics is that they're moving towards this simultaneous approach of analyzing multiple biomarkers at once through a series of genomic sequencing technologies. And so it's really important to think ahead of the curve to make sure that these newer technologies, there isn't a lag between patient access to these new technologies. And with that, I'd like to acknowledge my supervisors, Professor Martin Eisenman and Dr. Koen Degeling, as well as Professor David Westerman and Dr. Piers Bloomberg from Peter MacCallum Cancer Centre, who have been brilliant in assisting me in this review. And now I will take your questions. Thank you.
Thank you, Marty. Do we have any questions for Marty?
I can go first.
Go ahead, Ambrish.
Yeah, thank you, Marty, for such a nice presentation. I would like to understand, were there any specific drivers of cost effectiveness across the different studies which you found in your systematic reviews? Like all of or most of these studies would have done sensitivity analysis and would have reported. So was there any particular trend which was coming out of different studies? Okay, these are the things like, again, something which is improving compliance. That is one of the major driver of cost effectiveness, because this is one of the important insights which usually come out of systematic reviews of health economic analysis, that what is the component which actually either increase the cost effectiveness or decrease that?
Yeah, no, that's a very excellent question. No, thank you for that, Ambrish. So I can definitely illuminate that one of the things that we see with these molecular biomarker tests driving the cost effectiveness is less so about the test itself, but more so on the cost of treatment that comes after the test. So in the sensitivity analysis, increasing the price of the test or decreasing the price of the test doesn't really make that much of a difference. But what does make a difference is the decisions that come after the test. So I talked a bit before about the companion diagnostics tied to quite often novel treatment. And these novel treatments are very expensive, and it is the price of those novel treatments more so that is influencing the cost effectiveness of the test.
Okay, yeah, got it. Thank you.
Okay.
Do we have any other questions for Marty? You can just unmute yourself or raise your hand. Okay, if we have no more questions for Marty, that would bring us to the, there we go. Tan has 2 hands up. Go ahead, Tan.
I can't let you off the hook there, man. Marty. A question is, has modelling work been done for the Australian context? Because I'd imagine there'll be differences in, like you said, like different, like novel interventions and what standard care is would be different in different countries as well. So yeah, just curious if what's been done from an Australian perspective in this regard.
Yeah, no, thank you, Tan, for your question. So something that didn't really present is like, where did the publications come from? And predominantly the publications are European markets. And to directly answer your question, no, there hasn't been a study in Australia to date. And again, I think that really comes down to the rareness of blood cancers here in Australia, and difficult for industry to get that particular evidence for HTAs. However, with that being said, that's something that I would like to develop further within my PhD, considering that there isn't much out there for health economic evidence. I do think that it's a critical gap that hopefully my future PhD projects will add to.
Thanks, Marty. So we are now at the end of this session. I would like to thank all of our wonderful presenters. The research was so interesting. It's just so amazing how much research that us students are doing, and we don't get a chance to actually share with each other what we're doing. And also to thank all of the attendees for participating in this session. At this point, we would like to have our attendees vote for the best presentation during this session. I will launch a poll, and you just vote from that poll, and subsequent to that, we'll announce the best presenter. Here we just have a few more persons to vote. Okay, so I think we actually have a tie between 2 of our presenters. So our 2 presenters who won the best presentations are Clara Marquina from Monash University and Martin Blue from the University of Melbourne. So we will get in touch with you in terms of a token for your winning that award. So thank you very much. And we will just end the session here. Before we end the session, I just want to thank all of the presenters for today, our presenters from this morning, our student presenters, and all of the attendees for coming to the symposium. Additionally, I would like to give a special thanks to the organizing team. Everybody worked so hard in the background to get everything organized, and throughout today, everybody was working in the background, even though you didn't see their faces. Also, I would like to thank our faculty advisors who have been giving us lots of support throughout the past year, and our colleagues from the Sydney ECR and student chapter who we worked along with on this symposium. We will be sending out some feedback forms because, of course, there must be improvement in everything that we do. I did post the link for the feedback form in the chat, so you can, if you have time, you can just click on the link from the chat, or you will get it via email. And lastly, we want to invite you to our happy half hour, which will be immediately after this session. The link was sent in the registration emails that you got. So we just want to have a chat with everybody, inform you about new things that are coming up with our student chapter, and give you some more information on ISPOR and any ideas that you would like to share with us. So thank you very much, and thank you for attending. And I guess we'll see you next year if we don't see you in the happy half hour. Thank you.